Okay, so now that I'm audible, we'll jump into the session. Before that, a brief introduction. This is Dr. Gautami Priya. I've done my step 1, step 2 CK, and I'm ECFMG certified. I've been training students for the past 3 years, and I'm currently in my dermatology residence while mentoring USMLE students. Okay. So, talking about the behavioral science for a moment. So, in this next 1 hour, we are going to talk about behavioral science. Okay, see, behavioral science is one subject that a lot of students neglect while they were preparing, assuming it's just communications and they can just cope up, they can mark the questions on the exam day and all. But technically, if you know some of the just and the easier things and all, it would become very comfortable for you to answer those questions on the exam day. Today what I do is, my goal is not just to make you memorize facts or something. We are going to focus on some of the concepts and how they actually appear in the USMLE style vignettes, and most importantly, how to choose the best answer among the given choices, because ethics is all about one choice will be better one among the given options, so you have to go with it. Okay, so in today's session I'll give you an idea on how to answer those things, and we'll walk through some of the scenarios together, discuss some of the traps that you might face, and we'll cover a few of the core concepts that you'll have to know in ethics. Okay, so in this session I might not be able to complete entire ethics. Okay, for the next 1 hour we'll sit on ethics. I'll try to cover as much as I can that will be helpful for your step examinations. All right. Okay, so let's start off the session. Before that, if you guys could let me know which year of medical college you're studying and from which college or which country you're from, that would give me an idea about how I can proceed further with the session. Just leave me in the chat box about which year and which country you're from. Or if you're a graduate, just let me know that, so that I can adjust the teaching style accordingly. All right. Okay, so what is so special about behavioral science? If you see the step 1 content specifications, okay, you can see the behavioral science and ethics together comprise of nearly 15% of the questions. Okay, 15% of the step 1 questions is approximately 42 or 43 you will get. So around 40 to 50 questions you will get alone from ethics on your final examination. Okay, so among 280 questions, if you're getting 40 questions, that means technically right now in 16 block test, in each block you're gonna have 2 to 3 ethics questions, which is huge, right? So what we have to do to train to answer those 40-50 questions: always understand the core concepts of ethics. Okay, number 1. Number 2, know how to rule out other options and choose the better one among the given one. Okay, and that's what I'll try to do for some of the important concepts of ethics in the session. Okay, graduate, India, anesthetist, India, and third year medical student. Okay, sounds good then. So we have graduates and we have medical students. That's interesting. All right, so we'll proceed with the session. Okay, so this is the importance of ethics. I just want to give you a heads up of what we are dealing with before we talk about the content. All right. Okay, so what I have done in ethics is, we are going to divide it into part 1 and part 2 in today's session. So this is the part 1 section. So in part 1, we are going to talk about consent, decision making, core ethical principles, and some of the ethical scenarios that can show up on your test sheet. Okay, we'll go one by one. If you're having any doubts in between or between the session, just feel free to let me know in the chat box. I'd be happy to answer you out. Okay. All right. First, let's talk about consent. What is a consent? When a doctor is performing some medical test or treatment or procedure on a patient, they are expected to obtain a certain authorization from the patient, so approval sort of. Okay, so this is actually the consent. Okay, there are few types of consent. First we have is implied consent. So implied consent in the sense, for example, let's say there is a nurse who came to you, she wanna inject you, so you just gave your arm, okay, or you just gave your arm for the blood pressure check, or to draw the blood and all. So all this indicate you're giving your arm voluntarily for that particular procedure. Okay, so this is actually implied consent, where you're giving your arm. That basically implies that you're giving the consent for that particular procedure. Okay. Right. Next we have is verbal consent. See, verbal consent in the sense, patient will tell you, okay, you can examine or you can do this procedure. For example, before you go to the x-ray room, you're going to ask, okay, I'm going to take x-ray of you. The patient will say, okay, I'm fine, go ahead. Or before you're doing any physical examination, you're going to tell, I'm going to examine this particular lump. So the patient will say, okay, go and examine. Okay. So these all comes under implied and verbal consent. Then comes the written consent, which is very important. See, written consent is something that you take for a lot of surgeries or procedures that we perform in the hospital. Okay, so example, like if you want to do an endoscopy or needle biopsy, or you want to treat a cancer like radiation, chemotherapy, or any surgery, if you're doing, you have to get a written consent from the patient. Okay, so these are the three types of consent that we see in medical practice: implied, verbal, and written consent. Okay, now what are all the required components of a consent? First thing is decision making. For example, if the patient is not conscious, or the patient is sort of in a delirium state or delusional state, at that time you cannot say the patient is having ability to make decisions, right? So for this, the patient need to be fully conscious, okay, and he should be able to make the decisions. Okay, so considering that a person should be able to make the decisions, we will rule out child here. That is why when you're performing a procedure in the child, you're going to take consent from the parent, not from the child. Okay, then we have comprehension. Comprehension in the sense, the patient should be able to understand what you're telling them. Okay, in some time I'll talk about interpreters, which will help in aiding if there is any language barrier between the doctor and the patient. Okay, right. And next thing we have is voluntariness, which is basically whether the patient is ready or not ready to sign the consent and all. Okay, finally, disclosure. In the disclosure, you're going to talk about all this following things in a procedure, the brain things. What are the brain things? The benefits, risks, alternatives, indications, and the nature of procedure. You have to cover all of this while you're taking consent from a patient. You cannot skip any of this. You have to tell what would be the alternate procedure also if the patient couldn't perform this particular surgery or anything. Okay, so that is about the components that you'll have to look for in a consent. Okay, right. So that is about the required components in a consent. Now let's see a ethical scenario over here. Okay, among an attending, a PGY3 resident, and an intern, which is a PGY1, who should take the consent from the patient? Think about it for a moment and let me know in the chat box. if there's attending PGY3 and a PGY1 or an intern, the best one is very good, attending. Okay, so attending followed by PGY3 followed by intern. Okay, best is attending if they are available. PGY3 also can take it, considering if they have enough knowledge about the procedure and its after effects and all. Basically, they should know all of this about the procedure to take the consent. Okay, generally you avoid intern, particularly when for the procedures that they don't know or they're new to. Okay, so generally they should not do independently in most of the cases. Alright, so this is about consent. If they're asking who is the best would be the attending. PGY3 is also fine, considering they know what procedure they are doing and everything about it. And if you're talking about intern, they can independently obtain only if they are very experienced and no one is available in very rare situations and all. Okay, better would be attending and then PGY3. Alright. Okay, now what are the exceptions of informed consent? So just now I told you, in informed consent we have implied, we have verbal, and also we have written. So where do you get exceptions? Like without consent you can perform something. So these are the list. First we have is a life-threatening emergencies, like particularly after a road traffic accident where the patient is unconscious and no surrogate is present. In that you can do emergency surgery or treatment without taking consent. Okay, then if the patient is lacking the decision making capacity but they have the surrogate who authorized the procedure, then you can do it. Like the patient is in some psychiatric problem or they are unconscious sort of thing, but there is surrogate who the patient appointed and they allow you to do the procedure, then also you can do the procedure without taking consent from the actual patient. Okay, the patient decided to waive the legal right of informed consent. Sometimes the patient can waive, like I don't want to know, just tell everything to my son or to my daughter, they will take care of it, don't tell me anything, they'll be the one who will do everything that is needed for me. Then also you don't need to take consent from the patient. Okay, last is disclosing may pose a threat to the patient or affect their decision making capacity. So this is where a fancy term, therapeutic privilege, comes into play. What is this therapeutic privilege? This is actually the act of withholding information by a clinician with the underlying notion that the disclosure would inflict harm or suffering upon the patient. Basically, you are withholding certain information from the patient. Why? It's better you don't share it to the patient than sharing it, because if you share it, it might harm the patient. I've added here an article example. Okay, so you can just go through this article after the class, but pretty much what is happening is there's a woman who's admitted in the hospital. She's having multiple comorbidities and disorders and all, and her husband died in the hospital while she was also being treated for multiple cases. Then if the doctor team were to inform that her husband has died, then she may decompensate medically, requiring reintubation and further ventilator support. That is why children were requested that for the therapeutic privilege be utilized, and the physicians can withhold the information about her husband's death. Okay, this case was reviewed with our hospital ethics committee, who were supportive of utilization of therapeutic exception to withhold the information from the patient, from her at the request of the family members. So this is how you basically use the therapeutic privilege, wherein you're going to withhold some of the information from the patient that might harm the patient otherwise. All right. Okay, so this is about the exceptions to the informed consent. Okay, what did we see? Life-threatening conditions like emergencies and all, or if the patient is not in a stage to make a decision, or if there is someone who was already appointed to make a decision, or if whatever you're saying might harm the patient. So these are all the things where you don't need to take consent from a patient. Okay, now let's talk about minors. See, for minors, if you need to do anything, you're going to rely on the parent or guardian who will take decision. Okay, for example, if you want to enroll a minor for research or any medical care, who will give the approval or who will give the consent? That would be parent only. Okay, there are few exceptions here also, wherein you can ignore the parent request, or you don't need to wait for the parent consent. What were those? First one is emergency and life-saving conditions, same like adult population. Second one is minor is legally emancipated, or care regarding sex, like STIs or contraception or pregnancy care. Okay, addiction care, like we have drugs, we have alcohol. For all this, you don't need parental consent. Or minors who are parents, like they themselves have kids, like teenage pregnancy, etc. Or if the minors are married, in all the situations you don't need parental consent. Okay, the minors can get treated directly by talking to the doctor. Okay, all right, so that is about the exceptions to the consent and the consent for the minors that you have to know. Okay, right. Now, what are the situations where the parent cannot refuse the consent? So this would be a life-threatening emergency condition, like where you have to do certain procedure on a minor, but the parents are refusing it. You can go ahead, take approval from the ethics committee, and you can go ahead and do the procedure. Okay, examples include here meningitis treatment, or if you're doing some sort of blood transfusion, etc. Okay, what about vaccines? See, let's talk about this vaccines thing, because this is interesting and USMLE loves to test this topic. Okay, see, vaccines you can administer in two situations. One is life-threatening condition, like for example, if they're having a dog bite or a risk of tetanus, or in routine immunization like MMR, flu vaccine, etc. Okay, so now my question is, which vaccines the parent will have the right to reject, which vaccines you can, parents cannot refuse the consent among these two? Take a moment and let me know. Perfect. The routine vaccination is something where the parents can have the right to withhold. Okay. However, in life-threatening condition, even though the parents are not giving consent, you can go ahead and give the vaccination. Okay. But even in routine immunization also, if the parents say they don't want vaccination, the question might ask you as a doctor, what would be your next best step? What would be your approach? So the physician should always ask the open-ended question. Why do why the parents don't want the vaccine? So this is how you're going to talk. You're not going to put any judgmental tone or judgmental question. It should be an open question. Why are you rejecting vaccination? Why you don't want your child to get it? Okay. And then see what the patient is talking and what their concerns are. Then you talk about risks and benefits of getting the vaccination. Okay. This, as a doctor, as a primary care physician, you're going to do every single time to convince the parent in favor of vaccination. So any option that basically stating doctor telling them, try vaccination, this will prevent your child from this complication or this problem, or what are your concerns, this all would be your correct options whenever the patient is denying vaccination for their child. Okay, so that is about vaccination part, wherein if the parent reject it, you cannot administer it forcefully, particularly in routine immunization. Okay, you're going to talk what were the concerns are, clear them up, and try to get them convinced for the vaccination. Okay, this is what as a doctor you're gonna do. Okay, now we have another interesting scenario. Okay, let's talk about it. For example, you're doing certain surgery. Okay, and when you cut down abdomen or thorax, you open and you found out, okay, there is some unexpected finding is there. Okay, for example, if the patient is stable, okay, and it's a non-emergency, whatever finding you're going to find is a non-emergency finding. Okay, now what will you do is, in between the surgery, you'll not do anything. You're going to complete the surgery, whatever you have cut open the patient for. Okay, and you're going to inform the patient after recovery that we have found a certain mass or anything, and now you obtain consent. If needed, you can do another surgery while working on it. Okay, here you're basically obeying autonomy of the patient. Autonomy is a core ethical principle. Am I audible now? Let me know if you can hear me in the comment section. Perfect. Okay. So let's go over some of the clinical scenarios for this situation. Okay. So number 1, liver tumor found during cholecystectomy. Should we wait for the patient consent, or should we proceed with the surgery or treatment? Should you basically remove it in between your surgery, or you get the consent once the patient wakes up? Yes, so basically here the patient is stable and it's a benign thing. Okay, particularly if they are concluding that it's a benign, you wait and get consent later. Okay, next we have is ovarian mass that is found during appendicitis surgery. So you're doing an appendicitis surgery and you found an ovarian mass. Should you wait for the consent, or should you proceed with removal of the mass? This is also not an emergency one. Okay, so you wait and then you get a consent. Okay, ruptured artery during a surgery. This is an emergency one, so you basically proceed without a consent. Okay, right. Patient consented for removal of benign appearing abdominal cyst. During surgery, it appears to be malignant and would require a much larger organ removing operation. Now, should you wait for the consent, or should you proceed with the removal? Basically, what you thought is a minor surgery has become a major surgery, considering it's a malignant and you have to remove a much larger organ. Now, what should we do here? No, we are not going to proceed because now the surgery is basically shifting to a major surgery. Okay, it's not a life threatening, the patient will not die immediately on the table. So you wait, you wake up the patient, you inform that when we opened your abdomen, we found out that it's more extensive than what we had taught, and it's a malignant, and it's going to need a bigger surgery than what minimal surgery we have taught of. Okay, so you inform them, get consent, and then you're going to treat this patient. Okay, so this is how you're going to manage when you have an unexpected finding in a surgery. All right. Now let's talk about decision making capacity. If you see, what did I tell you? While taking informed consent, the patient should be able to make decision, right? So that is what you call it as decision making capacity, wherein the patient can understand whatever you're talking about and can communicate you back. Okay, further, the patient need to be mentally competent. If the patient is mentally competent, totally fine and all, then basically you take the patient consent. For example, the patient have an advanced healthcare directive, like they have written what they want and what they don't want. Okay, advanced directive is where they give the legal instructions on who will be used to guide for the patient decision making. If they have that sort of written note, that will be the second priority. For example, let's see, there is this old guy who came to the hospital. Okay, if he's totally fine, you ask the patient, this is the procedure that we have to do on you, are you okay with it? This is the risk, benefits and all. You get the consent from the patient and you go ahead with it. But if the patient is not mentally competent, okay, then you ask if their family members are having any advanced healthcare directive, like the patient have written this is what I want you to do, DNP or I don't want an intubation, whatever they want, basically their requirements, if they have written anything or not. If they don't write anything, then the third preference would be if the patient is having any living will, which is a legal document in which the individuals pretty much describe their wishes regarding the healthcare, whether to withhold, maintain or withdraw the life-sustaining care. Okay, if they are incapacitated. So if they're having this sort of legal will, that is also fine. You go ahead and see whatever the patient written, you're going to proceed with it. If this is also not there, then comes the healthcare proxy. Okay, so this is a legal document that designates a surrogate who will make the decisions on behalf of the patient. Okay, and last we have is oral advance directive. This is an oral statement made by the patient when they are totally fine, when they are totally awake. Okay, so that is what is an oral advanced directive, and this is actually not very specific, to be honest, because you don't have any proof, right, that the patient have told. Basically, some of the family member or friend will tell, okay, when the patient was alive, awake, he used to tell me he don't want intubation or he want to be in this manner treated and all. So this is not very specific. It's very difficult to confirm. Okay, but you do take the patient opinion. If someone told, the patient have told this when he was awake and all, you do take that into consideration. The better way for the oral advance is if you could confirm it with multiple people. Okay, that would be the better way. Right? Next comes the next of kin. If the patient doesn't have any of this, like, they don't have an advanced healthcare directive, living will, they don't have any healthcare proxy or oral advanced directive also, you don't know. Next comes the next of kin, which is basically in this order they can take decision on behalf of the patient. First comes the spouse, second is adult child. If none of them are available, then it would be parent. If all these are not available, adult sibling, then comes your close friend. Okay, so this is the hierarchy of the decision making. Always a competent patient. If that is not there, any document that suggests the patient wants to tell you something, or any oral thing like the relatives know, okay, the patient would have wanted this, that would come into priority. And if that is also not there, then comes the next of kin in this exact order: wife, kid, parent, any sibling, and then comes the close friend. Okay, whenever you are checking whether the patient is competent or not, you're going to check out with these questions. Okay, you're going to ask the patient, what do you know about the condition or proposed procedure and treatment, to know if the patient understand about their situation. What does this condition mean to you? Like, for example, if they're having cancer, what do you think cancer is, and why do you think, or how do you think you need to get treated? Okay, so this is what you'll ask. And your doctor, how are you weighing your options? Basically, why are you going with treatment X, or do you understand the complications of this treatment or condition? Okay, finally, what would you like to do? If the patient is able to answer all of this, that means the patient is competent enough to make the decision. Okay, if he couldn't, then you're going to see if any of these are available to take the decision on behalf of the patient. Okay, so this is the hierarchy of the decision making. Okay. So the difference between advanced healthcare directive and living will is basically, in advanced healthcare directive, the patient will mention what legal instructions they need while making the decision. Like, they can write, okay, my son or someone will tell this, or I particularly, they will talk in a very legal manner. Okay, so that is what you're going to see in advanced healthcare directive. In living will, they're going to specifically, okay, do not resuscitate, DNR, do not intubate, GNI, no chest compressions. So they are going to specifically mention if they are incapacitated. Okay, so they will mention you in the options whether the patient is having advanced healthcare directive or living will directly. Okay, so that's about the hierarchy of decision making. Now let's see a scenario over here. Okay, there is a 72-year-old man who's having severe stroke. He lacks the decision making capacity. This is already figured out. He has no advanced directive or designated healthcare proxy. His daughter lives in another state and has not seen him for 4 years. His best friend, who has lived with him for several years and knows his wishes well. Who should make the medical decisions? Think a moment and let me know. What do you think here? Okay, so let's see how to answer this question. First of all, the patient is not mentally competent, so this is gone. No advanced healthcare directive, no living will, no healthcare proxy. Okay, none of this are there. Then comes the next of kin. In the next of kin, who comes first? So the patient is having a daughter, right? So that would come before a close friend. Okay, so to be honest, the person who will be surrogate for this patient would be daughter. Okay, this is the legal surrogate of kin. But the best friend should be consulted, because the best friend might know a best interest of the patient. If the best friend gives, okay, patient previously expressed this wishes, okay, like the patient wanted this, like this will become now oral advanced directive, then you go with it. Okay, if the best friend mentions it. If the best friend doesn't mention any oral advanced directive, then the daughter will take the legal surrogate of kin. Okay, so this is how you're going to deal in this situation. All right. Okay, next comes using the interpreter. So this is one of the USMLE favorite topic. They love to ask about questions about interpreter in step 1, step 2, everywhere. Okay, so I've tried to sum up all the things that they could ask about interpreter in this one slide. Okay, let's go over it. First of all, when to use an interpreter. Let's say there is a patient who came to you who does not understand English, like maybe they are Spanish speaking. Okay, but as a doctor, you don't know the Spanish. Okay, now you have two options. You have a patient relative who knows both English and Spanish and he can translate, and you have a qualified interpreter available. Okay, who do you choose as an interpreter between your patient and you? Is it the relative or a qualified medical interpreter? Absolutely, no doubt. This would be qualified interpreter. Okay, so you choose it, you don't choose the relative. Okay, qualified interpreter can be in person, they can be available at the hospital, or they can be available over a video call or a telephone. Okay, so always go with the qualified interpreter if they're asking whom would you choose among the relative and the qualified interpreter. Okay, now let's talk about a situation where there is emergency and you don't have any interpreter available. Now what will you do? You just have the relative available because you don't have any choice here, and it's emergency, like the patient is vitals are not stable and they are admitted to emergency department. In this situation, you will not wait for qualified interpreter because that might deteriorate the health of the patient, right? So you basically take help of relative in the situation. See, this is sort of exception, don't take it always. In any other given situation, it would be qualified interpreter than the relative. Okay, I will give you the order. So the order would be qualified medical interpreter greater than qualified bilingual healthcare professional greater than adult family or friend in the limited appropriate such circumstances like emergency, etc. When it is extreme emergency and you don't have any option at all, then you go with child. Okay, so this is the order of selecting the interpreter for the patient. Okay, now once you've figured out who will be the interpreter, what are you going to do? You're going to introduce the interpreter to the patient. Okay, and you're going to introduce yourself. Okay, and what would be the position of the patient? This also questions have been asked in USMLE. So how will the position? If it is a spoken language, like the patient knows Spanish, you know English, then how would it be? So the doctor will be here, and this is doctor. This is the patient in front of doctor. Okay, just beside the patient here. Okay, this is beside. Beside, you're going to have interpreter. Okay, if it is sign language, then the interpreter will stand behind the physician. Okay, for example, if this is the doctor, the interpreter will stand behind the physician. Okay, and the patient will be in front of the doctor. So patient, always the doctor should be facing the patient as if they are talking to each other. Okay, so this is how the whole time the situation or the communication should go on. Okay, now how should you communicate? Always address the patient, not the interpreter. Maintain eye contact. What do you mean by address the patient? You're going to ask, how are you feeling? This is the phrase that you're going to use. Okay, you're not going to ask the patient, how are you feeling? Okay, basically you're not talking to interpreter at all. How is she feeling? Sorry. Ask the patient, how is she feeling? This is wrong. How are you feeling? This is correct. Throughout the communication, you have to talk with the patient, not with the interpreter. Okay, so it should be a direct communication to the patient rather than asking details from the interpreter. Okay, avoid third person statements. Okay, ask the patient, what does she want? Don't do that. What do you want? How are you feeling? What is your complaint? Okay, this is the treatment for you. So this is how you're basically talking while maintaining eye contact throughout the communication. Okay, use the teach back method. You teach something and the patient will repeat it, and the exact words the interpreter will tell it and see if the patient understood. Okay, so here you're gonna allow little extra time for the interview to go smoothly. All right, so this is about the usage of interpreter. Always a qualified interpreter better than the relative. In emergencies you can take help of the relative. Okay, and this is how you have to talk to the patient using the interpreter. All right, okay, so let's talk about some ethical scenarios. Okay, so all of this can be tested. They don't have any specific core principle. We'll just understand as we are learning from the scenarios. Okay, there is a patient attender who expresses romantic interest in you and they invite you for the lunch. What will you do? Do you tell, okay, I'll not treat this patient anymore, then we'll go for lunch, I'll refer other doctor, then we'll go for lunch? Or do you deny it? Or what will you do? Always never have any personal relationship with the patient or even the attender. Okay, so basically respectfully deny it. Okay, any option that is denying respectfully would be your correct option. All right, senior doctor or attending is showing romantic interest, and if they invite you for the lunch, then what will you do? In this situation, what you have to do is, because they are your senior or they are your attending, you can deny it. Basically, you respectfully say no. Okay, or you can just tell them we can just invite other colleagues also if they are okay with it, as if it's a team dinner. Okay, right. This is interesting. A lot of us might have faced it. Okay, there is a cousin who called you and they have asked you for an antibiotic prescription for the sore throat. Should you give the prescription or not? Lot of us might have done this during medical school, or during later on to our relatives. Okay, might not be antibiotics, some painkiller or something. Okay, but always it's better if you don't prescribe anything on the call. Okay, so from next time, if someone calls you, ask them to take appointment and then only prescribe. Okay, don't give free prescription on the call. Okay, right. Your friend is having bloody nose during your trip and there is no other doctor nearby. Now, can you do some sort of treatment for this patient, or should you wait for the available doctor? In this scenario, this is little emergency, right? It's a bleeding nose that is happening and you don't have any doctor. Here, you can proceed with some treatment. Okay, you might have seen this in flight also. They call in doctors when there is emergency, wherein doctors can go and give some sort of treatment. Okay, which might stabilize the patient temporarily, help in recovering momentarily. Okay, right. Your sister is involved in motor vehicle collision and you're requested to perform the procedure. Basically, your sister is asking you to perform the procedure. What will you do? You are in the same hospital where your sister is admitted, basically. In this situation, the most appropriate thing is get permission from the primary attending. Okay, and you can be an assistant helping them. No, you'll not be a lead surgeon, but you can be an assistant. All right. Okay, so that's about some of the ethical scenarios. Okay, next, this is very interesting. Okay, so you have 3 patients. Okay, patient 1, 2, 3. Patient 1, after you've treated them, they felt very happy and they gave you a thank you note. Patient 2 gave you an Amazon gift card of $10. Patient 3 told you that they're going to give you a Porsche car, like they gave you keys because they're very happy that they were treated and now they're going back to home. So among these three patients, from which patient you can accept the gift and from which patient you cannot? Those who have watched Grey's Anatomy might know a little more about this. Very good. Patient 1, we will accept the card. Okay. Thank you note. Accept it. Good. Patient 2, $10 Amazon gift card. Patient 2 also you can accept. Okay. It's a not very monetary gift. It's less than $15. Not very huge thing. They just brought it out of courtesy. Any hand woven woolen item or anything that they have made or some $10, $5 thing you can accept, like fruits or anything. Okay. Patient 3 who gave you the car, basically you don't accept it. Okay. You decline it politely and tell that you're very happy that the patient recovered. Alright? Okay. Now comes the next scenario wherein there are two pharmaceutical company. Okay. Pharmaceutical company A and B. Pharmaceutical company A offered trial funding, a clinical trial for some sort of drug or some procedure that is going on, and also conference cost. Pharmaceutical company B offered to provide educational material on the Kegel exercises for the patient with urinary incontinence if you in the trial and all. Now, which pharmaceutical company? One second. Yeah. So now, which pharmaceutical company offer you're gonna accept as a doctor? Even though the pharmaceutical company is offering funding, conferences and all, you don't take that much benefit. Okay, so you don't accept the pharmaceutical company A offer, but B offer is something that is providing that will help your patients and all, so you can accept the pharmaceutical company B offer. Okay, so physicians can accept offer for trial funding only if there is no conflict of interest. That means whatever the company is providing will not interfere with the patient personal benefit. Okay, so they will not do any personal benefit in any monetary way or any way for the patient. Okay, second one is it should be approved by the IRB, Institutional Review Board. Third one is source should be properly disclosed to both institution and also to patients. Only in these three situations you can accept a trial finding from a pharmaceutical company. Otherwise, you can reject it. It's very important. This is also something a lot of students confuse with. Just note down these 3 points. No conflict of interest should be there. IRB should approve, and also the source should be properly disclosed to both the institution, the hospital, and also to the patients. Okay, and this is very important step 2 CK question. So if you're preparing for step 2 CK, do make a note of it. Okay, right. Then comes the core ethical principles. So till now we are talking about consent, we are talking about some of the scenarios, ethical scenarios, and we have talked about decision making, right? Now this is another important segment in the behavioral science. So this is your core ethical principles. Let me make it very easy for you in the slide. Okay, first of all, there are 4 core ethical principles that you have to know for USMLE. First principle is always respect the patient decision. That is final, even if the physician disagrees. This is actually talking about autonomy. So what is autonomy? This is basically whatever patient chooses, that is correct. So basically patient is king here. Okay, second one is act to the benefit of the patient. So basically you are doing something that will act in the patient best interest. Okay, this is actually beneficence. Okay, so beneficence, if you want to put it down in a simple word, basically you want to do good to the patient. This is beneficence. There is one subtype in the beneficence which is actually principle of double effect. What is principle of double effect? So this is where you prioritize comfort rather than the side effects. Okay, double effect. So, for example, if you give opioids, it can cause respiratory depression, right? But the patients who are having end of care life, you still give opioids. Basically, you prioritize the patient comfort over the side effect of respiratory depression. This is principle of double effect. Just see this once, okay? Right. Next ethical principle is the physician should refuse because it may cause harm. This is non-maleficence and very commonly tested ethical principle. Okay. So non-maleficence, if you want me to put down in a simple way, it's actually do no harm. Okay. Where you feel like whatever procedure will have more risks than the benefits, you tell the patient, no, this will cause you harm, I'll not do it because this can cause you in some harm. Okay. Last we have is treat patients fairly and equitably. This is actually justice, where you treat all the patients that are coming to your hospital just basically based on the medical condition requirement, and you prioritize only based on the emergency or requirement. Okay, no other basis like race, etc. Alright, that is justice. So what did we check out? Autonomy, wherein the patient is the king. Beneficence, wherein you want to benefit the patient. Non-maleficence, do no harm. And justice, where you treat everyone fair and equally. Okay, let's see some scenarios because they tend to test this core ethical principles a lot. A competent patient with cancer refuses chemotherapy after understanding the risks and benefits. You go with it. So which core ethical principle you're following over here? Take a moment and let me know. Alright, very good. So this is actually autonomy. Okay, so wherein basically whatever the patient is telling, you're going with it. Okay, patient don't want chemo. Why? Because the patient understood the risks and now they voluntarily saying I don't want it. They're competent. Okay, you go with the patient. The physician recommends antibiotics for bacterial pneumonia. So what would you do? Sorry, which core ethical principle it's going on here? Yeah, very good. This is beneficence. You want to do good to the patient, that is why you are recommending, the physician is recommending antibiotics. Okay, so the ethical principle that is followed here is beneficence. Okay, good. Patient with capacity refuses intubation and requests a DNR status. DNR in the sense, do not resuscitate. Very good. This is autonomy. Okay, so basically whatever patient is requesting, you're going with it. Perfect. Okay, next we have is patient requests an unnecessary surgery that has significant risks than benefit and the physician refused it. Which ethical principle the physician is following over here? Very good. So here the physician is rejecting or refusing it because it will harm the patient, right? So this is non-maleficence. Okay, do no harm. All right. Good job, everyone. Then we have us providing vaccination to prevent a future disease. Which core ethical principle is this following? Which level of prevention? There's something in ethics, primary, secondary, tertiary level of prevention. So if you're providing vaccination, this is primary level of prevention. Okay, the core ethical principle here is very good, beneficence. Okay, perfect, because you want to do good to the patient. Okay, avoiding a medication to which the patient has a known severe allergy. So is it autonomy, beneficence, non-maleficence, or justice? What core ethical principle is being followed here? Perfect. This is where you don't want to harm the patient. That is why you're avoiding the drug which you know can cause allergy to the patient. This is actually non-maleficence. Okay. Good. Then we have allocating a limited ICU bed based on medical need rather than wealth or social status. Which core ethical principle you're following here? Very good. This is justice, where you're treating equally and fairly. Alright, so this is about core ethical principle. Just go over the examples. Just remember buzzwords. Okay, autonomy, patient is king. Beneficence, you want to do good. Non-maleficence, do no harm. Justice, everyone is equal and fair. Okay, alright, so that is about the core ethical principles. Now let's deal with some of the ethical scenarios. Okay, first of all, an adult is refusing a vaccine or antibiotic drug because of religious belief. What will you do? Should you administer the vaccine or antibiotic, or should you stop it because of autonomy? So as a doctor, you cannot proceed with a vaccine or antibiotic if the patient is competent and they are refusing. But what you can do is you can explain the risks of not taking the medication. Okay, this is the first option that you have to choose. Anywhere where the doctor is open-endedly talking, okay, if you don't take the medication, these are all the problems that you will get. Why you don't want antibiotic? So if this sort of discussion you're seeing in options, go with it. If the patient is still denying, okay, there is a sequence question where they have mentioned even after you explaining everything, the patient is still denying, then you basically respect it. Okay, because of autonomy of the patient. Okay, a patient wants to try an alternative medication instead of the prescribed medication for hypertension. Then what would you know? What would you do? Like they said, I've read this in particular journal, that this is going to help for hypertension. I want to try this and all. Now what will you do? Now, and the situation, first thing is you're going to ask the patient everything about the medication. Okay, about the other medication. It might be herbal and whatever it is. Okay, if the doctor know it, if you already know about the medication, know it might help you, you can ask the patient, okay, you can start it, but you have to visit frequently so that I can closely monitor. Okay, this is the key thing. You'll not straight away refuse it. For example, if you don't know, if the doctor don't know about the medication and they're hearing it for the first time, tell them that you'll read about it and get back in the next visit. Okay, and if you already know, if they're mentioned in the question, doctors knows about it because he also read about the trials and he feels that is good, then you can tell, okay, you start the new medication. Particularly the better one is to start along with the existing prescribed medication, and I have to closely monitor it, frequent visits and frequent blood pressure measurements I'm gonna need over here. Okay, this is what you'll do. You'll not reject the patient to use any alternative medication. Okay, right. Then we have is an unconscious adult who was in motor vehicle accident, has already received fluids and has severe bleeding requiring transfusion before the emergency surgery. The accompanying driver claims the patient is Jehovah's Witness but has no documentation to prove it, and the family members cannot be contacted. See, Jehovah's Witness, in the sense they are they are certain group who does not allow blood transfusion because of their religious belief. Okay, but here in the situation, if you have any proof that they are Jehovah's Witness and they don't want any blood transfusion, if they have any written proof, then you stop it. But if you don't have any proof and nothing from the patient's side is coming that they don't want blood transfusion, in that situation, like here, proceed with the emergency surgery and give blood transfusion. Okay, but even if it is emergency and you are having proof or you having something that is stating the patient doesn't want blood transfusion because they are Jehovah's Witness, then you cannot proceed with blood transfusion. But if it is a child, for example, the situation will change. If it is a child, as I've told you, in life-saving situation, you don't need a parental consent. Okay, so even if the parent says that they are Jehovah's Witness, still you're going to give blood transfusion. Okay, so I'll write here Jehovah's Witness plus child. Okay, even though the parents deny it, you're going to involve the ethics committee and you're going to proceed with the blood transfusion if it is needed. But if it is adult, if they themselves don't want blood transfusion, you cannot do it. But here it is emergency and you don't have any proof saying the patient doesn't want blood transfusion, that is why you're giving the blood transfusion and doing the surgery. Okay, right. And patient's spouse calls and asks about the patient health status. Now what should you do? This is where doctors should be very diplomatic and we should hide things. Okay, so what we do is for the confidentiality of the patient, you can tell the patient's spouse that the patient is doing well. Okay, and you basically talk very vaguely. Okay, they're doing well, they're fine, or they're not very fine, very vaguely. Okay, you're not going to talk about any of the condition or treatment, nothing. Okay, and you ask the patient to visit the hospital to get further details. Okay, very importantly, you don't disclose the disease or treatment Okay, anything to the patient's spouse or any family member or friend. Okay, you only discuss it with the patient because of confidentiality. All right, right. So that is about the patient confidentiality. Okay, there are a few more ethical scenarios. Let's do them. Okay, so there's a patient who has a request for abortion which is against your religious belief. What will you do? When you cannot perform a certain procedure because of the medical your personal reason, you explain the same to patient. I cannot perform abortion because of this particular reason. Okay, and then but I can refer it to a doctor who can perform it. So you can totally refer it, okay, rather than you doing something that you don't want to do and against your beliefs. Okay, patient is requesting a CT scan for abdominal pain, which you know is due to gut. What will you do? You already clearly know what's going on, it's gut, but the patient is concerned that they might have a tumor or cancer and they want CT scan. What will you do? You basically avoid unnecessary intervention here. Okay, so you avoid the unnecessary intervention and you're going to tell, no, this is not needed for your situation. I'm going to give you pills to help you relieve the abdominal pain, and this is what you try to explain to the patient. Okay, after multiple times you explaining, if they are not rejecting, maybe you can do it, but the first thing you have to do is, no, this will do more bad than good because technically you're not having that particular condition. This is what you're trying to explain to the patient. And what ethical principle you're following over here by rejecting the CT scan? Very good. Non-maleficence, do no harm. Okay, you don't want to harm the patient. Okay, not autonomy, non-maleficence. All right. You've noticed alcohol breath in your colleague and he tells you his shift ends in 30 minutes anyway. What will you do? You are maybe a PGY1 or a PGY2 intern. I mean PGY1 or PGY2 resident. Now you're going to go and complain, okay, to your superior, like head of the department or GME head or anyone, to avoid any harm to the patient. Okay, so the first thing is talking with someone in your department, the head of your department, rather than going directly to ethics committee or state board, etc. Okay, first thing is your head. Then if they're not taking any further steps or anything, then you might go as a later intervention. You can go to the ethics committee or you can go to the state board, etc. There is a whole table wherein we will cover what concern to report to whom, which I'll talk in the upcoming sessions. Okay, you are taking a patient to OT and on the way the patient tells he or she do not want this procedure anymore. This is an important case. Okay, see, the patient, if you're taking patient to the OT, that means they might have already provided a written consent. So you already have a written consent where the patient signed, okay, saying that they are okay with the procedure and all. Now just before you going to the OT, the patient tells you that they don't want this procedure. What should you do? Should you proceed with the surgery or should you stop it? Use some common sense here. Okay, so the patient is panicked or whatever the reason, they don't want when they are entering into the OT. What will you do? Very good. So the patient is the ultimate decision maker, right? So here in the, even though they have signed a written consent or anything, right now the patient is saying they don't want it. You have to respect it. What you can do is asking why you don't want it. Okay, if there is something you can solve, fine. If not, you're going to send him back to the ward and you're going to take consent again, and then you're going to perform the procedure. Okay, this is what you will do. You'll not go with the procedure stating, okay, I have a written consent from you, I'll not have any legal problem, I'll go with the surgery. This is not how you're going to do. Ultimately, whatever the patient tells you at the end, at the moment, okay, that would be the final. Okay, a patient advanced healthcare directive says do not perform CPR, whereas the patient wife, okay, who is the next of kin, wants the CPR. Should you do the CPR or not? Now, very good. You're not going to refer to any senior or anything. You have this advanced health directive. Okay, if the patient is incompetent or the patient is unconscious, this is the better one. Okay, so this is what you will take into consideration. Respect the patient wishes. Okay, and you are not going to do any CPR. Okay, right. An alcohol intoxicated patient is admitted. The patient is refusing the treatment and the patient is demanding the discharge. What will you do here? You feel the patient is very intoxicated at the moment and might harm himself or the other people along the way. So what are you going to do? In this, you can involuntarily admit the patient. Okay, there is also a list wherein you can involuntarily admit the patient. One of them is the situation where the patient is intoxicated and can harm himself or others. Okay, so you can involuntarily admit because at the moment he is intoxicated and he does not have decision making capacity at the moment. Okay, once he is totally normal and once he can make decision, you can if he says he wants to go home and all, you can just send him. Okay, but at the moment you have to admit the patient or let him stay at the hospital. All right, okay, so these are some of the ethical scenarios that can show up on your exam in a very crisp manner. Okay, so just go through them once again so that you'll understand the gist of each of the scenario that I have put in over here. Okay, and that concludes our part 1. Okay, so what did we cover? We have covered about concerned decision making, we have covered about core ethical principles and some of the ethical scenarios. I know I have session 2 also, part 2 also to take, wherein I'm gonna cover all of this. Patient-centered interviewing, delivering bad news, gender and sexuality inconclusive. But I think it's been already an hour, so I will cover rest of it in the next session, wherein we'll do this 4, and we might have 2 more sessions wherein I'll cover 4 or 5 topics in each of the session. Okay, if you want links or details for further sessions, just reach out to the Next Steps team. They'll be able to guide you out. Okay, and these are the reference links that I have used for today's session. So for the articles and for some of the content, I have took from this links. All right, and yeah, so that concludes the behavioral science session for today, wherein we talked about some of the core and important concepts of ethics. I hope it was helpful and I hope you have understood the concept. If you're having any more doubts, I'll be here for a few more minutes. Just you can just let me know in the comment section. I'll be happy to clear them out. And for the upcoming sessions or further details of ethics, just reach out to our team. Okay. Yes, the recording of this session will be available on YouTube. You can just check it out later as well. Okay. Ma'am, my doubt was what would be the approach for adults refusing life-saving vaccination. If it is an adult and they refuse life-saving vaccination, you cannot do anything. You can let it be. Okay, you cannot forcefully do the life-saving vaccination for adult. Okay. Alright, so it was great to have the session and great to see you guys so energetic throughout the class. Thank you so much for attending the session, and we'll meet again soon. Okay, have a good day. Yes, recording will be available in YouTube for free of cost. You can just check out the video later on. Okay. But rest of the ethics sessions, if you want further details or links, feel free to reach out to our Next Steps team. They will be happy to help you out. Okay. Thank you once again, everyone. And I hope this 1 hour was helpful for you in your ethics preparation some or the other way.